Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to the 2024 ANAwareness Week presentation of Stereotactic Radiation with Dr. Michael Brisman of NSPC. You can stay up to date with ANAwareness Week and everything the ANA has to offer at anausa.org. We also hope you'll make plans to attend World Vestibular Schwannoma Awareness Day on June 22nd. You can find more information about that on our website and social media pages, Facebook, LinkedIn, Instagram, and Twitter. Our website is a great resource for so many topics you may have an interest in. There's a search function so patients can find just what they're looking for. The ANA is here to help, so please access those opportunities. So Dr. Brisman, if you'd like to turn on your camera, share your screen, and introduce yourself, we can get started.
Thank you. So I just want to check, can everyone see me and see the slides okay?
Yes, we can.
Perfect. Okay, great. So thank you for having me. My name is Dr. Michael Brisman. I am a neurosurgeon. I've been in practice here on Long Island, New York for about 26 years, and I have a special interest in two things. One is trigeminal neuralgia and one is brain tumors. And within brain tumors, I do see a lot of acoustic neuromas. And I have also an interest in trying to treat people with as low risk a technique as possible. And for acoustic neuromas, often that does mean gamma knife. So that'll be one of the highlights of my talks today, but I'll discuss acoustic neuroma in general. I've been the co-medical director of the Long Island Gamma Knife, which is the first gamma knife on Long Island, which we put in over 20 years ago. We've treated thousands of patients. We have millions of people who live in the Long Island area, so we have a pretty big experience. The hospital is now named Mount Sinai South Nassau Hospital, and thank you for having me. So acoustic neuroma, which is also known and maybe more appropriately as vestibular schwannoma, these are best seen on MRIs. The left view here is an example of an MRI where there's a very large acoustic neuroma, and these are tumors that arise from the eighth cranial nerve, which is a combination of the cochlear or acoustic component that provides hearing, and then there's also a vestibular component to the nerve that is involved in helping us maintain normal balance. So these tumors really arise from the vestibular portion, not the acoustic portion of the nerve, and they're really more technically considered schwannomas, but nonetheless, we often commonly refer to as acoustic neuromas, and it's understood to be the same thing. They tend to occur here. They arise from the nerve, the vestibular nerve, where within the internal auditory canal, and then they if they get bigger, can grow into this area, and this area here is called the cerebellopontine angle, because here's the cerebellum down here, and here's the middle part of the brainstem, the pons here. So this area where if they get bigger, they can grow into is called the cerebellopontine angle. This is showing, again, sort of the anatomy better, where here's the brainstem, here's the cerebellum. The brainstem has a lot of important things running through it, motor, sensory pathways. The cerebellum is involved in coordination. This is the trigeminal nerve. And again, the acoustic neuroma comes from, if you look on the opposite side, here's the seventh and eighth nerves, which run together, but the acoustic neuroma arises from the eighth nerve in the cerebellopontine angle. So presenting symptoms usually are going to relate to eighth nerve function, which can include things like decreased hearing in that ear, ringing in the ear or tinnitus, problems with balance, headaches if the tumor gets bigger, and also facial numbness if the tumor gets bigger and presses on the trigeminal nerve. So it can present with a lot of things, but tends to present with eighth nerve symptoms. And again, now that we have MRIs on every block, these are going to be found pretty early. So usually people don't have too much symptoms when they're found, because people, if they start having a little hearing problem, a little ring in the ear, they usually go right for imaging, and we'll usually pick the tumor up when it's smaller. So more and more we're seeing these tumors when they're smaller. And again, things have really changed completely with acoustic neuroma discovery and management. One, because we have better imaging. I mean, consider that it wasn't until the 80s when we had CAT scans readily available, and it wasn't until the 90s and 2000s when we had MRIs readily available. So those really allow us to see the thing well. And it's only been recent that we have proliferation of gamma knife and units that, other similar units that can treat these. So the diagnosis is really based on imaging, and the best imaging is really the MRI, and ideally it's with and without the intravenous gadolinium material. Again, could you see it on an MRI without contrast or a CAT scan? Yes, possibly, but not always. And really that's going to be the best kind of sequence for seeing it. And again, fortunately, because we live in the United States, this is a wealthy country. I mean, usually a lot of us in this country will have access to an MRI, and your referring doctor will be able to get you imaging in a pretty timely manner to find out if you have this or don't. So the diagnosis can be made by, different doctors. I mean, it's usually not necessarily diagnosed by a neurosurgeon, and it can be diagnosed often by an internist, by a neurologist, by otolaryngologists or ENT doctors, sometimes by neurosurgeons, sometimes by audiologists. But obviously, there are a lot of different doctors who could potentially pick this up. And again, the way they're going to pick it up is going to be with symptoms and by ordering an MRI. The natural history of acoustic neuromas is that the tumors grow, and they can grow to be pretty large. Sometimes they are very indolent. They don't grow much at all. They can remain very small for many years. There is often hearing loss that develops in the affected ear on that side. And again, it would only affect the ear on that side. And sometimes that hearing loss can develop over time gradually. Sometimes it can occur in a stepwise manner. So all of a sudden, a person can find they have 50% of the hearing that they had. Sometimes that gets better. Sometimes it can be lost and not recover. But it tends to be that there's going to be progressive loss of hearing. But again, it's a little unpredictable exactly how that progression is going to occur. So treatment options, I mean, generally, as far as treating the tumor itself, are going to be to observe the tumor, to do an operation on the tumor, or to do radiosurgery, which is kind of a hybrid between surgery and radiation, where we're using focused radiation sort of in a manner like if we were going to do surgery. So it's a surgical procedure that people like myself, neurosurgeons, do with a radiation oncologist, but it's super focused, and it isn't like regular radiation, and it can accomplish the same thing the surgery can. Now, there are certainly medicines that we could use and other treatments we can use for hearing loss, for balance problems, but as far as treating the tumor itself, these are really the main choices. And unfortunately, we don't really yet have a medicine that will just make the tumor go away, even though medicines are definitely used for certain aspects, of the treatment. So just to go over some of the anatomy, that's in there, and I kind of showed you that picture at the beginning, but one reason it's kind of important is to understand like what symptoms could you experience, without a treatment, what symptoms could be experienced as a result of the treatments, and a sense of the complexity of where these things sit. I mean, they're sitting among the cranial nerves, among the cranial important blood vessels, and usually against the brainstem if they get bigger. So the tumors arise from the internal auditory canal, as I mentioned, and in this canal is where the 7th and 8th cranial nerves run. The 8th cranial nerve is a combination of the cochlear nerve, which is involved in hearing, and the vestibular nerve, which is involved in balance. But also in that canal, running right along the 8th nerve at that segment, is the facial nerve, which controls movement of the face. Of interest, the facial nerve, which is a motor nerve, is much more robust than the 8th nerve, which is more of a sensory nerve. And the seventh nerve, the facial nerve, is usually not affected, even when the tumors are very large. The only time facial nerve is usually affected is a result of the surgery itself. So that's important to be aware of. The tumors tend to occur anatomically in the cerebellopontine angle, as I've discussed. The they if they get bigger, they can grow between the cerebellum and the pons, the brainstem. And the fifth nerve is also nearby, which controls feeling in the face, the trigeminal nerve. And sometimes, if the tumor is big enough, people can experience a numbness in the face from compression of the trigeminal nerve, or in sometimes more or less commonly, something called trigeminal neuralgia, where people get episodes of sharp pain in the face. Again, not that common, but I've seen quite a few cases. And then lower down, below the seventh and eighth nerve, is the ninth, 10th, 11th nerves, the lower cranial nerves, which involve with things like swallowing, speaking, which again are usually only going to be affected in the event that the tumor is very big and that they get manipulated at surgery. So these are two MRI pictures just to show this. People get a sense that there can be a large variation in the size and the growth rates of these tumors. On the left is a tumor here where my arrow is. It's a pretty small tumor. On the right is a pretty big tumor that's distorting not just the cerebellum, but also the middle of the brainstem, the pons. Also of note is the brain drainage pathways. The brain has its own plumbing system. It makes cerebrospinal fluid, or CSF, is a water-like fluid that bathes the brain and the spinal cord and gets reabsorbed. That drainage pathway drains down through this structure here, the fourth ventricle, which is one of the ventricles, one of the cavities. And in rare cases, if the acoustic neuroma is big enough, it can distort this fourth ventricle, so a person can develop buildup of the fluid spaces, or hydrocephalus, usually which could require drainage of those fluid spaces, like with what's called a ventriculoperitoneal shunt, the tube that goes from the ventricle, the fluid space in the head, to the peritoneum, the abdomen. And again, that's not common, but can occur. Sometimes it can occur from the mass effect of the tumor pressing on the fourth ventricle. Sometimes the tumor can release some chemicals into the cerebrospinal fluid and can produce the hydrocephalus that way, but that's rare. These are more medium-sized tumor, which are more commonly seen. So these and the smaller tumor, the ones that we see more commonly. This kind of enormous tumor is just not seen that much, anymore, or at least in our country, fortunately, because people, when they get a little bit of a complaint, they immediately get an MRI, and it doesn't get to be that big. And these are, again, some other images showing the different size tumors here. And this is a very large one here that's, again, causing a lot of distortion of the brainstem, the cerebellum. So as far as surgery goes, there are three different major approaches. One is called the suboccipital retrosigmoid, where the incision is behind the ear, and we're going behind a vein called the sigmoid sinus. This is the one that most neurosurgeons use. This is the main one that's used nowadays. This is the only one that I really use. There's another one called the translabyrinthine presigmoid, where there's a similar kind of approach behind the ear to get to the tumor, but here we're going in front of the sinus called the sigmoid sinus, and you're going through the bones that are involved that have critical hearing components in them. So if this approach is used, there's definitely going to be no hearing afterwards. And again, this doesn't clearly offer any benefit to the first approach. Then the third approach, the suboccipital middle fossa approach, involves going from the top of the ear, and this is really only used for very, very, very small tumors. And again, nowadays, since I believe it doesn't make sense to treat a tumor unless it's very big, I never use either of these two bottom approaches, although again, there's different philosophies about treating these. So this is the standard suboccipital surgical approach. I will say that when I do this, and I think a lot of people, we use much smaller incisions. We don't go from here to here. It's more like an 1.5 inch incision behind the ear. A piece of bone is removed, usually not this big. and the dura, the parchment-like layer over the cerebellum, over the brain, is opened, and then we can access the tumor. This is the cerebellum. We don't necessarily put a drain here, but we release the cerebrospinal fluid. Things become relaxed. This is the dura tented back. And then here, surgically, we're looking at the tumor. This is where we're looking over the cerebellum, which is under the retractor here. Here's the tumor here. And again, you see the trigeminal nerve above, a vein. There's going to be arteries above here that are important: superior cerebellar artery and anterior inferior cerebellar artery. The seventh and eighth nerve are going to be intimately involved with a tumor as large as this. They go into the internal auditory canal. And then the lower cranial nerves, which are involved in swallowing and speaking clearly, are here. There's a posterior inferior cerebellar artery under here. So there's a lot of very important arteries, veins, not to mention the brainstem underneath this. The surgical technique usually involves gradually coring these out. And in the past, the approach involved trying to often drill this bony canal here, the internal auditory canal, and then trying to remove all the tumor, including peeling it off the facial nerve, the seventh nerve, at the bottom of the dissection, which is often what caused people to have facial weakness afterwards. And I think that new philosophy is, first is I only operate on these tumors when they're huge. And even then, I usually just debulk the tumor rather than peeling it off the cranial nerves, and then I'll leave a piece against the nerves and just do radiosurgery or gamma knife to the remainder. And that way, I think you really reduce your complications, which are mostly associated with trying to get 100% removal of the tumor and trying to peel it off the cranial nerve at the bottom of the dissection. This is showing like a normal anatomy. And again, you kind of see like that there's a lot of, this is without the tumor, but there's a lot of important things in here. And again, I mentioned there are 3 important cerebellar arteries, there are important veins, all the cranial nerves, the brainstem, the cerebellum. So again, even a little thing here that goes wrong, and even at a small percentage of time, could be a serious thing. This is an example of someone who had, this is from a textbook, someone who had surgery on acoustic neuroma and ended up having some weakness of the facial nerve of the face because the facial nerve was irritated. And here you see the person can smile and move the left side, but the right side doesn't move. And if a person develops this, sometimes it will get better over time. It often will if the nerve is left intact. One thing that one has to protect particularly is the eye, because if the eye is not blinking properly or closing, then a person can get injury to the eye, dust can get into the eye. So if this happens, we have to protect the eye by covering it at night, using regular eye drops. And if the eye really doesn't close for a long time, then we would consider putting like a gold weight in the eyelid to get it to close, or doing other things to help it close. But the truth is, this should rarely happen nowadays. And I've treated hundreds of patients with acoustic neuromas. I have never had anyone, by the way, who died. I've never had anyone who had any kind of permanent facial paralysis, anything more than the smallest amount. And again, it's not because I'm using better technique, but it's because of the choices of technique that I'm using. I'm tending to choose safer, I believe, or lower risk interventions. So the risks of the open surgery are certainly real and include hearing loss, include balance, dizziness problems, include weakness of the face, include meningitis or leak of the clear fluid out the wound, include chronic headaches, include numbness or pain in the face, include bleeding or stroke or even death. Now, maybe a serious problem is not the norm, but it certainly can occur in a certain amount of time. And obviously, if something's serious, then it's very serious for that person. So I've done a lot of what I like to call my bloodless brain surgery or stereotactic radiosurgery, most of the time using a machine called gamma knife, which is not a knife at all. It uses a lot of gamma radiation beams to essentially perform surgery without cutting into the head at all. And again, I think this is a trend in surgical disciplines in general, where people are going to want to treat the same kind of problems with lower risk, less invasive maneuvers. And this is certainly one of the major maneuvers that we're using in brain surgery. So what is radiosurgery? Well, stereotactic radiosurgery, or SRS, it's a non-invasive technique to deliver a single high dose of radiation to a limited, well-defined target volume while avoiding nearby normal tissue and structures. Sometimes we will use like a 5-session treatment, which we call hypofractionated, because it's not as much as standard fractionated radiation, which might be 20 or 30 fractions or sessions. But most of the time, particularly for acoustic neuromas, we're treating in a single session. This is an example of one of the versions of Gamma Knife, and they're always coming out with newer versions, and every few years, different centers will buy the newer version of it. But this is one of the more recent versions called the Perfection. And you see here that people will lie on this stretcher here, and prior to getting onto the stretcher, we apply a cranial frame to the person. There are little pins we put into the scalp, which are applied under sedation. I usually inject numbing medicine into the scalp, and I have an anesthesiologist give medicine to the patient to knock them out for 5 minutes while I put the frame on. They then get an MRI or other images, and then they go into this machine here. The doors open up, and inside are some focused radiation beams that all focus on the tumor and can essentially cure the tumor. And the sessions usually last like 30 to 60 minutes, and it's a one morning treatment, and people then go home. This is what the inside of the machine looks like. And there are these, again, beams of cobalt, which are releasing gamma rays, which go through these collimators and focus on a center point. And by telling the computer where exactly the tumor is and moving the person's head throughout the treatment a little bit, we can get the beams to focus right on the tumor. And it's very, very conformal. And the key to radiosurgery or Gamma Knife are two things. One is having a treatment that's very conformal, so the beams are going to be right where we want it, right on the tumor. And the other is we want the radiation to fall off very quickly from the tumor. And the key to doing it is this arrangement here, where you see, this is how we treat something deep in the head without injuring the superficial part. So each area on the surface is only getting one beam, but at the center, it might be getting hundreds of beams, and that's how the center point gets a meaningful treatment, but the other areas of the brain, get only one beam, and it's safe and doesn't do any harm. So I just want to show you a little bit about what Gamma Knife does in general, so you have some sense of what it could do for acoustic neuromas. This is an example. This is one of the more common things treated with Gamma Knife, which is brain metastases. So if someone has a cancer in their body, like a lung cancer, breast cancer, colon cancer, and it spreads to the brain, people can get these tumors in the brain, like I've outlined here. And Gamma Knife can be used now as a one-day treatment instead of treating with over 30 sessions the entire brain. And people can use the chemotherapy to treat the rest of the body, but the chemotherapy often doesn't get into the brain well because of the blood-brain barrier. So we use Gamma Knife, and here's someone who we did, the yellow is the area where we treated the tumors. The person had 3 tumors, and this is an MRI 6 years later. This is one of my patients. And 6 years later, you see the tumors were still gone, and this person was doing well 6 years later. Ultimately, this patient did unfortunately succumb to her systemic disease, but she remained good from her brain viewpoint. The Gamma Knife successfully treated her brain disease. This was someone this was a physician I treated who came to me, who lived in Manhattan. She was 67. She had some headaches, but it wasn't bad. And she had this was a benign tumor on the surface of the brain called a meningioma. And this person actually, I didn't do Gamma Knife for. I did a different type of machine called a Novalis, but it was a linear accelerator which emits X-rays instead of gamma rays, but it's the same general idea. And here's the treatment plan. We treated her in 5 sessions, and then over time her tumor shrank and she did very well. She had no more symptoms. She was happy with things. Here's an example of a patient with a pituitary adenoma, another type of common benign brain tumor. This fellow was in his 50s. I had removed this tumor transsphenoidally, so through the sphenoid sinus, through the nose with it, and this tumor had recurred here, and these tumors are often near the optic nerves here, but because this is very focused and very rapid fall off and very conformal, we're able to treat this and sparing the nearby nerves. Here's the treatment plan on the axial images. Here's the nerves here, the eyes. Here's a coronal, a different sequence looking face on. Here are the nerves above the tumor. Here's the focus plan. And then years later, this is a few years later, the tumor is totally gone. This patient did very well. Here's another type of benign abnormality called an arteriovenous abnormality. This was a teenager, a girl who was having some mild symptoms of some numbness on the opposite side of her body. And this is a left arteriovenous malformation, an abnormal tangle of arteries and veins that people are born with, and they can bleed or cause seizures. And we did a gamma knife treatment for her. Here's the yellow is where we treated her. And this causes the blood vessels to clot off over time. And here's several years later, you see the thing it's gone completely. There's no more risk of seizures or bleeding. And again, this is just another example of another benign abnormality that we could treat with a very low risk method. This is another type of benign condition that one of the main things I treat is trigeminal neuralgia, where people get sudden sharp pains in the face, usually thought to be due to a little blood vessel touching the trigeminal nerve or multiple sclerosis. And it responds to a little bit of an injury to the trigeminal nerve. And here's one way of doing that treatment where we do gamma knife. Here's the brainstem. Here's the trigeminal nerve. This is a patient I treated. We did a little radiation to the nerve. Here you see the nerve, the gamma knife. This is right just on the nerve, only a few millimeters big. And I saw him 15 years later, and he was still pain-free and doing very well. So the different types of radiation that could be done for acoustic neuromas include gamma knife, which is a one-day treatment. Other types of focused radiation with X-rays, which are called linear accelerators, which deliver that, can also do one-session treatments. Hypofractionated or 5-session treatments, and sometimes people do 3-session treatments. And also, one can sometimes do 20-session treatments. And the reason one would do 5 or 20 would be if the tumor was bigger. So to me, the gold standard of radiosurgery is gamma knife because it's been around the longest. It's very precise. It's has very rapid fall off. It has the most data, the most consistent, most accurate. It's how I do most of my acoustic neuroma treatments. But again, certain larger treatments I will do with linear accelerators treated over 5 or sometimes even 20 sessions. We've learned a lot about dosing of the focused radiation treatments over time. So the results have gotten a lot better because we've learned how to do it. And we now know that you can get facial nerve problems if you use what's called 14 gray or 1400 centigrade. So we don't use that dose. And hearing problems can develop over 13 gray. And the good news is you get good tumor control between 12 and 13 gray. So for most acoustic neuromas, we're using 12 to 13 gray to the edge of the tumor. We've also learned that if you minimize the radiation dosage to a nearby hearing structure called the cochlea, that will also improve the likelihood of good long-term hearing. So here's an example of a patient that I treated 20 years ago for an acoustic neuroma, and she did very well. The tumor was essentially cured, it shrank, but just to show you, again, again, 2 keys of the gamma knife treatment, this is one of the yellow, we treat to the 50% isodose line. That means that 100% is going to be in the middle, 50% is half of the hottest amount, let's say, of the radiation. But the key things are, one, the yellow where we're treating to is very conformal to the tumor. We treat to the 50% because that's where, with gamma knife, the fall off of radiation is going to be fastest. And the other key things to see is how quickly the radiation falls off. So here's the 40%, the 30% isodose line. So what that means is that the radiation that the tumor's getting here you're almost at half that amount just a few millimeters later. So that is the key thing about radiosurgery, is that it's focused and a rapid fall off. Conformal and rapid fall off. An example of Gamma knife for acoustic neuroma. This is about a centimeter big, and she had some hearing loss, but not much. And we treated her. This was, again, 20 years ago. The yellow is where we treated. And this is the yellow with some of the green. You see the quick fall off. And this is like almost 15 years later. You see the tumor never grew. She essentially was cured. So this is, again, just showing, I think, again, rapid fall off, conformality, and successful treatment without any operation, without any of the risks of a regular operation. Now, I should mention that Gamma knife isn't 100%. So maybe it's 95% successful. Maybe 5% of tumors, particularly bigger tumors, may continue to grow and may need further treatment, whether it's surgery or a repeat Gamma knife. Gamma knife also has a possibility that hearing could still decrease, but usually we say that hearing will be preserved about 60 to 70% of the time at the hearing level where it is at the beginning, so at the time of treatment. So if the hearing is pretty good at the time of treatment, there's a decent chance that hearing will be preserved down the road. Whereas if a person has minimal hearing, when we treat them, they probably won't. And that's one of the reasons why it may make sense to treat people before they have excessive hearing loss with Gamma knife. There was also mention of, well, is there a possibility with radiation? Could a person develop a tumor or cancerous growth? And the answer is, it's not impossible, but very, very, very unlikely. I mean, the likelihood of tumor development after radiation is related to how much area is getting radiated and time. So the area that we're treating with Gamma knife is usually a very tiny area. So usually the likelihood is not too much. I mean, it's not that it's zero, but the likelihood of, maybe it's, 1 in 1,000, 1 in 10,000 of getting another type of tumor as a result of that, but it's which is much, much lower than the likelihood of something very, very serious happening as a result of open surgery or craniotomy. So it's not zero, but it's very, very low, but not zero. I'll also mention that some people with Gamma knife may or may not continue to have ringing in the ear, may or may not have balance issues, may or may not have some temporary facial weakness that develops, but I've never seen any permanent facial weakness, at least when I do it. I'll also say that a lot of people are doing these. Some people have different levels of experience. Some people are using different types of machines. So I do think that someone who is doing a lot of treatments with Gamma knife, such as myself, who has a good record of treatment, is likely to have better outcomes than someone who hardly ever does a treatment or is doing different equipment or other things. So I don't think it's all going to be the same result, but I think in the hands of someone who does a lot, I think the outcomes are excellent often. This is a person who had some decreased hearing and a medium-sized acoustic neuroma. And the yellow is where we did the treatment. And here her hearing did decrease over the years, but she still has some hearing in that ear, which is useful. But also you see how the tumor really shrank pretty significantly over time here. This was several years later. So again, most of the time people will be cured after Gamma knife treatment. This is an example of somebody who has acoustic neuromas on both sides, or bilateral acoustic neuromas, which is seen in a condition called neurofibromatosis type 2, or NF2, which can be inherited. This is rare, but sometimes we will see these, and these patients require a little bit of a different consideration. We usually see these patients earlier, like when they're younger. Here's an example of such a patient who presented in her 20s, and she had acoustic neuromas on both sides. This is the one on the right side. This is the left. And again, the images are reversed on MRI. And she had minimal hearing in the right ear to start with and some headaches. And we did first a Gamma knife on the right side. And what you see here is years later, the right side got a lot smaller. Also of interest, her hearing got a lot better on the right side, which is unusual, but it's possible. Now the left side did increase over time, and we then did a Gamma knife on the left side too. But again, much less morbidity or risk or complications with Gamma knife, in my opinion. And again, these patients did very well. People with NF2, which is again a certain number of people with acoustic neuromas, will also get tumors in the brain and spinal cord elsewhere besides the acoustic neuromas, and those can also be effectively treated most of the time with Gamma knife or radiosurgery to the brain and spinal cord as well. This particular patient I've treated several times for other brain and spinal cord tumors, and she remains in excellent condition, having had, I've only operated, regular operation one time for her. She had I was found to have a significantly sized spinal cord tumor. But other than that, now we monitor her brain and spinal cord, and that was the only open surgery she ever needed. It used to be these patients had many, many operations of the brain and spinal cord and often had a lot of problems. She, ended up, doing totally fine, looks like a normal person, has, minimal, if any, symptoms, and, has went on to have children, has a normal family and normal life. So here's a concept I want to also mention is it's been understood more recently that part of hearing preservation, one of the things that might help is minimizing dose to a nearby hearing structure called the cochlea, which is outlined here in blue. So one thing that we do now routinely, if a person is getting a Gamma knife treatment for acoustic neuroma and they have hearing, is that we outline the cochlea and try to minimize the dosage of the cochlea, and that is definitely useful as well in preserving hearing. So here's an example of that same patient that I treated, where you see the in yellow the acoustic neuroma treatment over, from up to down or down to up, and the contouring the cochlea. And again, this patient did very well. And most of the time, I'm treating acoustic neuromas with Gamma knife. Some patients with very small tumors, like if it's under 5 millimeters, I won't treat at all. I just observe. And if it's small, or if it's stable, or if the person's, older, we might just leave it alone completely. I mean, the only time I really am operating is for very, very big tumors. And even then, I'm just debulking the tumor and then, not peeling it off the cranial nerves, and then just doing radiosurgery for the residual. So here's an example of one that I treated like that. This is a person who had a pretty big tumor. It had been rapidly enlarging. It had bled into itself. She had symptoms. So this person I operated on, and again, here, this is the after surgery, and here you kind of see sort of my philosophy, and I think a lot of people are doing this now, or some are, where we kind of leave the tumor alone in the canal, leave the tumor against the brainstem and against the cranial nerves, and we take out most of it. And her symptoms all got better. Her hearing did not get worse. Often the hearing gets worse when you try to remove a big tumor in entirety. She had no facial nerve weakness. She went home a few days later, and we just did some focused radiation for the remainder. So I think that's the way to go. If there's a tumor that's very big that has to be removed, which again is definitely the exception. Follow up after Gamma knife or after tumor or after, for observation only is going to be with MRIs. Often with Gamma knife or with focused radiation, there will be some central necrosis before the tumor shrinks. So there may be, actually the tumor may swell a bit for the first 6 to 9, 12 months. Then you may see internal dying off of the tumor, and then it may either stabilize or shrink over time. If there are clinical exacerbations from a little swelling or irritation related to the treatment, we can sometimes use a brief course of steroids like a Medrol dose pack, and that will usually help with that. So here are some journal articles that kind of demonstrated the results of Gamma knife, which, and these are like 20 years old. So we've known for many years that most of the time you do not need an operation, a formal operation, open surgery and you can instead do the radiosurgery. And by the way, I treat patients with open surgery, with radiosurgery like Gamma Knife, and with observation. I just think that most of the time you're going to do better if you don't do, the bigger open operation. So this study, which again came out over 20 years ago of Gamma Knife, show and things have progressed since then. We've learned about the cochlea and learned more, but again, showed that you could have very good tumor control with Gamma Knife. The likelihood of major permanent facial weakness was zero in this study, and hearing was maintained most of the time. This was another study, also 20 years ago, again, showed excellent tumor control, major permanent face weakness. Again, I've seen zero. I've had no patients with any facial weakness from Gamma Knife. I mean, other than I've had one or two patients who had like a little bit of weakness like months later that lasted like 3 weeks, but nothing. And hearing level maintained most of the time at the level that you come into the treatment, but not always. So thank you. So again, I want to, in summary, I think there's a lot of interesting information out there. You can Google things, you can watch the procedures. It's important to get different ideas and different opinions. Certainly, everyone doesn't share my exact philosophy, but I tend to believe that the person who wants to do the lowest risk thing that's still reasonable is, that our bias should be towards that guy's opinion when it comes to brain operations. That's the theme of my book. That's the theme for acoustic neuromas. And again, I would say that I have excellent results with acoustic neuromas, not because my fingers move better than anyone else's fingers or my equipment is somehow more elegant, but because I tend to choose Gamma Knife or radiosurgery when possible, and again, sometimes just observing the tumors if they're small or stable. And when the tumor is very, very big and we have to operate, I will just debulk the tumor, not try to threaten the critical brain and cranial nerve structures or vascular structures, and do radiosurgery for the remainder. Thank you. I hope this was helpful. And anybody who ever wants to contact me, you can call my office. You can call me on my cell phone. People give you my cell phone, and I'm happy to help anybody anytime with phone calls, FaceTimes, or any other way I can be of assistance. Thank you.
Dr. Brisman, thank you so much for your presentation and time. If you want to go ahead and stop sharing your screen, we'll jump into a few patient questions that we had here. Great. The first one is asking about radiation effects. So can radiation affect bones in the neck area or dental decay?
So I think wide field radiation, I mean, yes. I mean, if you're having, if you had like a lot of radiation to a tumor in your neck, it could. If you had a lot of radiation to your teeth, it could, but I think the standard radiation that's being done for acoustic neuromas, a gamma knife treatment for acoustic neuroma would not be expected to cause any problems with teeth or any problems with neck or anything like that.
Gotcha. And what percentage of patients do you see might end up having radiation versus surgery or versus just staying with observation?
So I would say it really depends who you go to. I mean, because there are different philosophies. I mean, first is the philosophy has changed over time. I mean, in the past, there were people surgeons, if you went to them, 100% of the patients got surgery. Now, even the doctors who do a lot of surgery are offering a lot of gamma knife. But I would say it depends who you go to. Now, with me, I would say that most of the time I'm doing gamma knife. There are patients who have very small tumors. Again, under 5 millimeters or less, I'll usually leave alone. It could be 5 millimeters up to a centimeter and a half, but if it's been stable, I might leave it alone. But most of the time, it's going to be gamma knife. If it's somewhat bigger, I might do 5 session or sometimes even 20 session radiation. And I would say surgery for me is rare. I mean, it's going to be, maybe 3 to 5% of the time when it's a very big tumor. But that's my algorithm is most of the time I'm not, but I think it depends a lot on who you go to. I believe that I'm doing it the best way. I mean, obviously, I think I'm doing it the best way, and I'm doing it the way I would do it for myself or a family member. But there are definitely, for whatever reason, different philosophies, and I believe over time that people are going to move more and more towards my philosophy. But that's my philosophy.
Absolutely. Kind of on that same track, we have someone who's still in the decision-making timeline and process, and they've had differing opinions from different doctors on surgery or versus radiation. Obviously, size plays a factor into that, but what other factors might affect the decision making for that?
So, I mean, number one is each person has to be decided on individual basis. So, I would need to, if you were asking me, I would need to, talk to the person, understand the symptoms, the complaints, see the picture. When you talk about size is itself a complicated idea. Are we including the measurement of the internal auditory canal, which is a centimeter itself? When we say something is 3 centimeters, are we saying it's 3 centimeters by 3 by 3? Is it 3 by 2 by 1? When we, even within an exact same size, it can look very different depending on the person's anatomy. So the same tumor in a 65-year-old might look totally different than a 20-year-old. Then it also might be exerting different, compression amounts on the brainstem, on the cerebellum. Is it causing hydrocephalus? Is the person having a lot of symptoms? So again, I would say it has to be looked at individually, but as a general rule, most of the time, I think one can get away with a focused radiation. But the only way to tell really, I mean, if you show me, I'll tell you my opinion, but I think it depends on the size and the symptoms and what that person's individual anatomy is. But, as a rule, most things under 3 or 3.5 centimeters can be treated with focused radiation, most, but not all. And I think one has to look at the individual case. I had a patient, I mean, I'll just give you, I had a patient 20 years ago, a fellow who was 65, who had an acoustic neuroma was 4.5 centimeters. And he presented with hydrocephalus. And, he had headaches, balance problems. So I put in a ventricular peritoneal shunt. And after that, he was totally fine. And we discussed different options. And we did a 20-session radiation treatment on him. This was 4.5 centimeters. And he did fine. And over time, it shrank to 2.5 centimeters. He never had an issue. So it depends a lot on, again, the individual, not just the size, but what's it doing to that person? What are their symptoms? What does their anatomy look like? But most people can be treated without surgery to remove it.
Thank you. We have a couple more. This person says they're about a year past their stereotactic radiosurgery to treat approximately a 2 centimeter tumor. 4.5 months after treatment, they had some serious head and ear aches that were treated with steroids and improved. But then about 7 months after treatment, they had facial eye and balance issues. Is there anything that could treat these delayed effects, or would they go away on their own by chance?
Okay, so again, let me start by saying that when we say someone had surgery or someone had radiation, each treatment is different. So I mean, I know what I'm doing. I can't speak to everybody's experience. Different people are treating with different machines in different ways. So that's the first thing is I don't know exactly, each person's case is different. That said, a lot of times symptoms will improve. Some of the symptoms that people develop with acoustics that can be bothersome relate to vestibular nerve problems like balance problems. They can get tinnitus, and some of these problems are a result of the treatment, the focused radiation. Sometimes it has nothing to do with it. I mean, it may be that had you done no radiation, that over time you might have developed some of those symptoms. So we don't always know, is it treatment or is it just the natural history? These kind of things sometimes get better on their own, can be challenging. And let me say to all the people out there, there are doctors like myself who care a lot about you. And you should understand that what it's really about is patience and making people better and we are sympathetic and empathetic with you. And I feel bad if I can't always make people completely better. Sometimes for balance issues, we can recommend things like vestibular therapy. Some of the things headaches, obviously there are medicines for headaches. Another thing that I tell people as far as treating things is that, and I treat a lot of facial pain also, but understanding that whatever your problem is, whether it's an acoustic neuroma problem or any problem, every problem is two problems. And people don't realize this, but if I can explain to you why it's two problems, it might help you make it better. So every problem, whatever it is, you don't have a Lamborghini. I don't know. You're not happy. You don't have a sports car. Okay, you have two problems. One is you don't have a Lamborghini. The other problem is that it bothers you. So every problem is, so if we could take your pain problem, your dizziness problem, your whatever problem it is, and make it not less bothersome to you. So there are a lot of things one can do to make things less bothersome. There's a very good medicine that I try on a lot of patients called gabapentin. It's not only good for nerve pain, but it's good for making things less bothersome. Antidepressants can often help. Physical therapy or vestibular therapy can help. Massage therapy, acupuncture, anything that reduces your stress. Support groups are great. Just talking to people, being heard, knowing that there are people who care about you and want to listen and want to try to help. Anything that brings joy to your life or makes things happier, getting a good night's sleep, drinking plenty of water. So I would say, I don't know for sure to this person if your problems will get better. I certainly hope they will. And nerves and the nervous system have a lot of resilience and may get better over time. But it's important to understand that there's a wide range of things that can make you feel better. That, if you work with us and you work with your support group members and your doctors, that I think there's a lot of hope for stick with it, work with us. And I think there's a chance we can get you feeling better. And often it's a multimodality approach, doing a little this, little this, little this, that can get you feeling better. So I hope you feel better.
Absolutely. Yeah. There are a lot of different ways to find that support, like you were saying. And a similar question here to finish us off. Do you see a lot of patients having issues with fatigue as a possible side effect with radiation?
Not too much from gamma knife. Now certainly with regular radiation that's done over 20 or 30 sessions, where you're treating a large range of, whether it's the head or other body part, then in those cases, certainly fatigue is going to be a component that could last a few weeks. I mean, at least, and again, everyone is doing things differently, so I'm not going to speak to everybody. And there are some people who have much bigger tumors. But I would say for most people who are getting gamma knife, you're treating a pretty small area. And I would say that generalized fatigue is not, common, not something that I see all the time. Certainly one wants to see one's internist, your family practice doctor, check your blood tests. Often, people are on polypharmacy. They're on a million medicines. And sometimes people are fatigued from one of the many medicines they're on. There could be other reasons. Does one have a depressed mood? Is one under stress? There are a lot of things that can contribute to fatigue, but I would say that is not typical, at least in my experience, for gamma knife treatment for acoustic neuroma. But certainly anything is possible. And again, best to that would not. That concern is a minor concern in treatment. And usually I will recommend gamma knife. I think it's the way to go. But I think if a person has that, it's important to work with their doctor to try to improve those symptoms.
Well, Dr. Brisman, thank you so much for your time today and your presentation and taking some of those questions. We appreciate all that you and the NSPC do for the ANA and partner with the ANA and acoustic neuroma patients all over. Thank you so much.
Thank you very much for having me, and thanks for all you do. Thank you very much.
All right.